well. Hello, everybody. Good morning, good afternoon, good evening, and welcome to our panel on the political economy of strategic purchasing in low and middle income countries. The idea today is to introduce some methodological background to understand the topic, and then we will have three additional presentations. One is a comparative analysis on purchasing in private public contracting in low and middle income countries, and then two country experiences, within Argentina and one in Indonesia. The idea is applying the political economy perspective through strategic purchasing that we're achieving key health systems goal in the context of implementing national and health financial programs. The questions are about the institutional and political drivers of implementing strategic purchasing, and what are the lessons learned at the country experience. The session we will be organized over 4 presentations, and our participants are Dr. Sumit Mazumdar from India and UK. He belongs to the Center of Health Economics and University of New York. Daniel Maceira, myself, from Argentina, professor at the Department of Economics at the University of Buenos Aires. Dr. Harsbullah Trabani from Indonesia is chief of party of the USAID health financing team in Indonesia. And Dr. Ayako Honda from Japan. She's professor in economy at the Sophia University, Tokyo. Thank you all for being here. And so our first presenter will be Dr. Sumit Mazumdar. Sumit, please, welcome to the stage.
Yeah, thanks, Dan, and welcome everybody for joining our session, which is on the political economy of health financing, and particularly focusing on strategic purchasing in low and middle income countries. So I'll just talk about the key issues on and some kind of a theoretical consideration of the framework of a political economy framework of strategic purchasing. So the motivation is like strategic purchasing has come out as a kind of a main a key focus of health financing reforms worldwide, as a part of the purchasing function, as we are all aware. Now, this is mostly undertaken by public and quasi-public agencies as purchaser and the private sector providers. So it involves some crucial aspects and questions on public and private roles, and then like what to buy, from whom to buy, the technical aspects of which we call as 3 C's, like costing, classification, and contracting, like more on how much to pay, how to buy from the private providers, and then the institutional capacities and frameworks. Now, it's well known, but just to recap, like purchasing is strategic only when it is aligned to the key goals of the health system, and is connected in a way to provide a performance. So in a way, it's about using purchasing as a policy lever. So like in the classical way, on public role, like moving more from what we call as a rowing to a more steering function. So using purchasing as a more policy lever in a stewardship role. Now, designing and implementing strategic purchasing, it is it is not just technical, it hinges critically on the technical contents and the more fundamental drivers, which are like political drivers, economic, institutional conditions, and governance. But unfortunately, it remains a bit less inadequately considered, although there are some measures now. So, in starting, like, of course, time is very short, so I'll just skim through this very briefly. So, we want to distinguish between what are the structural and the instrumental drivers. So, uh, in the way we are conceptualizing organization and its distinctive features, the evolution of the institutions, and so on, are forms the structural context. So within which policies are conceived, designed, and implemented. So in a way, the political economy questions serve as defining the terrain, or like the who, which, why, when of the policy choices. Issues of governance, and that make a bit a distinction between the governance approaches and political economy. So in our conceptualization, governance are more instrumental drivers. So like it is, and you have the definition here from the WHO report recent. So it is more of how to questions, to set the rules of the game. So when given the contextual role of as I say, the political economy dimensions, governance is more on thinking of how to an optimal rules of the game. So political economic questions, as we say, and like in other aspects of health policy, is they involve considering the balance and distribution of power, which is the politics element in it, and the distribution of incentives. So the balance and distribution of power and the balance and distribution of incentives between the different actors and the institutions and their functions is what provides the political economy basis of uh, strategic purchasing. So I won't be able to talk much in greater detail about the conceptual framework, but just to give you a flavor of it and the highlight, and I'll just maybe allude a bit to it. So we have divided it into four broad domains, the framework, and there is a kind of progressive nature to it, so that the first one leads to the next, and gradually in that way. So the first is the contextual foundation. So where we call of the structure. I'll just briefly move to a more formal presentation of it. So it is mainly considers the characteristics of the health system, the legacy of reforms, how the market is organized, the different ideologies and values that defines the public policy system, the forms of political, administrative, and legislative organization, the political settlement. Now, political settlement again is a sublime concept, a very important concept in itself, which provides a sort of the theoretical background to it. So, like, for people who are familiar to the political settlement approach, that political settlement is basically an arrangement between the institutions, actors, the political system, which exists, the difference, balance of power and interests between the different groups, which kind of exists, as a basis. So it's believed like a reform or a measure or a strategy works only when it is aligned to the political settlement, which is the kind of the existing arrangement. So like the political settlement of the status quo. Then we talk about the different actors and the actions, the typical stakeholder arrangement, but kind of distinguishing between the different actor and the roles. Then moving on to the distribution of resources and incentives between these different actors and actions. There are common issues like, support for reforms, ownership structure, financing, how it develops agency issues and transaction cost, which brings in the dimensions of institutional economics into it. So how the different, because there is a lot of agency and contract theory dimension involved, starting from when the purchaser acts as a principal on behalf of an agent on behalf of the principal, which is the general population, or for whom the health services are being purchased, and then the agent enters into a contract with the provider. So, and then there is a lot of the questions of transaction costs, and more so like in enforcing these in particular cases. So, for example, whether to see there is actual adherence to the contractual conditions. So, where, for example, the provider is required to confirm certain conditions. And then, of course, the big question of corruption and rent seeking. Speaking of LMIC context, when purchasing is being done, like even simple traditional procurement is not free from the kind of problems with corruption and rent seeking by certain constituencies. So this also happens to affect it. Then finally is institutionalization. So when as an interaction of the contextual foundations, the roles of actors and their actions, the distribution of resources and incentives, a system evolves. That's called what we're calling as a new political settlement, like getting the buying in and support for the reforms. Then the need to institutionalization talks about how to consolidate, to internalize the reforms so that it's more sustainable and moves ahead. So talking of the wider sectoral reforms within outside health sector and the new political reforms. So I'll just kind of uh, talk of to give you the flavor. So this is, sorry, it's some issues. Anyway, I think time is also less. So we first will try to share the finer details of it, and this is in a way where we like to go about it. Then of course there are the key steps in which we would one would like to go for conducting the political economy analysis. So we follow the kind of the problem driven approach from Harris. So like stating the problem and distinguishing between the intensity and the stage, and followed by the structural diagnosis of the context and institution, which is the number one component in the framework. So the more institutions, groups, arrangements, what as the actors and the actions here, and the kind of contextual foundations. So the agency diagnosis is what is very important on talking about the power, incentives, influencing behavior. So these will involve the actors and actions and the distribution of resources. So once this diagnosis is done, it is important. But I know it has to be kept in mind that political economy analysis works best. Traditionally, there was a notion that this is a post diagnosis. So when an event happens, a policy is being implemented, you go with political economy approaches to dissect and understand why something worked and something did not. But the kind of framework we're talking here is a more ex ante framework. So before a program is launched, you can, it's preceding policy launch, so that to test the different ways in which a program needs to work and a policy maneuver, but is also possible concurrently. In just, I have about 3 minutes. I'll just talk very briefly, trying to take the political economy framework. The latter presenters will talk in greater detail for other country examples, particularly Indonesia and Argentina. But I'm just give you, for people who are familiar here, there is not much time to talk of, but the Pradhan Mantri Jan Arogya Yojana, the PMJY, is India's flagship public health insurance program now. Hospitalized illnesses, but covering in insurance cover for hospitalized illnesses. But under this program, for the first time in India, at a national scale, there are smaller provincial examples. The purchasing from private providers for hospital services is taking place in a big way. And naturally, in a diverse polity as in India, it's opening up a lot of new questions. The question, like, for example, just to give you a flavor of it, to just a broad overview. So, for example, there is questions on how the policy is steered with political resistance and reluctance in opposition ruled states, where the states, the national party in power is not and then also the question with respect to sharing of financial resources and political returns, like why would an opposition government want to portray a national program where the political dividends might lie with the national government. Now, for this policy, a strong political leadership, like which, as of now, the nationalist government in India has a strong, is portrayed to having a strong political leadership, which is apparently a critical binder. But in other states, on moving ahead, there could be a question of sustainability. There are big questions of competition, cartelization of private sector providers, and in the post-COVID scenario, there is already some kind of potential inflationary pressure under the contractual obligations. So this brings the questions of transaction costs and the questions of agency approaches to it and how you go ahead with it. The big question of interest groups, India is a market. I didn't get the chance to talk about it, but the basic foundation is of the work in how the market is organized, where already the private sector is dominant. Then purchasing by a party which is not having a dominant share creates new questions. And this also goes in the ancillary input and factor markets. So there is the strong political leadership as of now. The central are more so a centralized model is being able to move through a few technocratic reforms, for example, in the IT, but core competences and institutional capacities that are critical to building purchasing or to move to a strategic purchasing is still perhaps less attended and not in the forefront. So that's all. And thanks for having any questions later on. Thank you. Over to you, Dan.
Thank you, Sumit. Perfect time. Thank you for your very interesting presentation. Our second presenter is Ayako Honda. Ayako, please. This is your stage.
Thank you, Dan. Before Dan and Hezbollah is going to discuss, their countries experiencing strategic purchasing and political economy issues, I will just briefly discuss governance issues associated with strategic purchasing and implications for purchasing private healthcare in publicly funded systems based on a past research experience. A number of years ago, the Resist Research Consortium undertook a study to look at how healthcare purchasing is functioning in 10 Asian and African countries. And the multi-country study identified a number of governance-related issues that affect how healthcare purchasing impacts on efficiency, quality, and equity in healthcare service delivery. Addressing these governance issues includes improving the implementation of strategic purchasing-related interventions by developing a shared understanding of the healthcare purchasing function and clarifying the roles and responsibilities of those involved in the interventions. Also, coordination of multiple and parallel purchasing mechanisms that operate within a health system, while considering the signals sent by the various mechanisms and how funding flows are shaped by the relative size of the funding, payment mechanisms and rates, the services provided, the population covered, and accountability mechanisms of each mechanism. And development and articulation of mechanisms that hold our purchasers and healthcare providers accountable to the citizens. The RESIST study also considered what governments can do to facilitate strategic purchasing in the purchasing relationship between government and purchasers. And the government actions identified include setting direction and designing policy that enables strategic purchasing to improve efficiency, quality, and equity of healthcare service delivery, providing regulations and other types of legal frameworks to facilitate purchasers' strategic use of tools to improve the performance of health systems, and improving the capacity of the actor groups, including purchasers who are involved in strategic purchasing. We also realized that many countries in Asia and Africa have reformed or are reforming their health financing systems in an attempt to progress towards universal health coverage. And these reforms quite often involve moving to public contract model of healthcare financing with organizationally separate healthcare purchasers and providers. And as a result, an increasing number of publicly funded systems are purchasing healthcare services from both public and private healthcare providers. However, we also realized that there seems to be some gaps in knowledge about the purchasing arrangements being used between public purchasers and private healthcare providers under publicly funded health systems, including knowledge of payment methods and rates. So the Amarech Obse from University of Cape Town and myself undertook the literature review of policy documentations to look at purchasing arrangements for public and private health services in LMICs under publicly funded health systems. And the literature review particularly looked at the types of private purchasing that is made under publicly funded systems in different healthcare markets, and the payment arrangements established under publicly funded systems with a focus on payment mechanisms and rates for public and private providers, and the key issues in developing payment arrangements for private healthcare purchasing under publicly funded mechanisms. The slide shows the healthcare purchasing mechanisms examined in the literature review. The literature was obtained from online portals of governments, the research organizations, international development agencies, and academic citation databases. When the information was unavailable online or in published documents, the direct communication was actually made with health administrators and researchers in the countries where the healthcare purchasing mechanisms operated. So that's a brief explanation of the methods for the literature review. And we found that the private healthcare purchasing operates under different types of publicly funded health systems, which can be classified as mandatory health insurance systems that purchase healthcare services from both public and private healthcare providers. Tax-funded systems which contract private health providers alongside publicly funded public services, and social protection mechanisms such as user fee exemptions mechanisms for poor and vulnerable populations. Unfortunately, due to the limited amount of time, I don't think I'm able to fully explain the results that we identify from the literature review. I just want to highlight 4 key messages based on our the documentation review. So the key messages from the literature review include, first of all, a transparent mechanism is really required to establish justifiable payment rates. Without a clear basis for payment rates, it may be difficult to determine whether healthcare purchasing arrangements impact on efficiency in the use of public resources, and also to design payment arrangements for private providers so that they send signals that encourage equitable and quality health care service provision. The mechanism also requires adequate engagement with healthcare providers in order to make the process transparent, reduce provider dissatisfaction with payment rates, and in doing so, mitigate any unfavorable consequences for patients that are associated with provider dissatisfaction with payment arrangements. The second message is that the clear definition of the roles and responsibilities of public and private healthcare providers is required in order to determine justifiable payment arrangements with private providers. This includes specification of the types of services to be provided by public and private providers, and services for which public providers receive government budget and salaries on top of other publicly funded service payments. It should also be noted that government facilities provide prevention and health promotion services in addition to the benefit entitlements covered by mandatory health insurance. When mandatory health insurance covers specific segments of the population, such as formal sector workers, those not covered by insurance access healthcare services under tax-funded system. So these are perhaps the factors needs to be considered to determine the payment arrangements with the private providers under the publicly funded system. The third message is the payment arrangements should include carefully designed incentives that direct private healthcare providers to deliver efficient, equitable, and quality healthcare services. This requires the government and or the public purchasers to carefully examine the healthcare purchasing market, including the interactions between incentives sent by multiple healthcare financing mechanisms. The last message is government should create some statutory framework that allow public purchasers to design payment arrangements that enable the strategic purchaser of private health care in the public system for the efficient use of resources, and that discourage unfavorable provider behavior, including differential treatment of patients and or balance billing that can reduce equitable access to quality healthcare services. So this is the end of my presentation. I think what I discussed here was not terribly sort of related to political economy, sort of the issue, but then perhaps the areas that political economy or the consideration to political economy is required. Thank you very much.
Thanks a lot, Ayako. And now it's my turn to present. Okay, so in this case, I'm gonna present the public-private strategic purchasing in Latin America with a specific focus in the case of Argentinian social health insurance schemes. In general, what we see in Latin America and the Caribbean are they are countries characterized by a huge inequality in income distribution, and that produce segmentation in their healthcare systems. In general, population health coverage rely on income, the ability to pay, as well as Ayako mentioned, the job status. Formal workers have social insurance schemes, and they are allowed to have access to different packages of healthcare services according to depending on the country. The institutional financial protection mechanisms are key to provide homogeneous access to certain healthcare services and goods. In some cases, you have countries where the government defines specific packages of services, and in other cases, they are basically supply-side subsidies where you go to the hospital or healthcare centers and receive care for free. In any case, out-of-pocket expenditures in health is a key indicator of how equitable or unequitable healthcare systems behave in the region. Just for having some view of comparative expenditures and health indicators across Latin America and Caribbean, what we see is a difference of 56 times between Trinidad and Tobago, the country that spends the most in terms of healthcare expenditures per capita in international dollars, against 80 in the other extreme of the chart. the difference in under-5 mortality rates is 11 times. There is no, even though there is a trend, higher income, higher expenditures are correlated to better results. This correlation is not perfect, and is associated to the organization of the healthcare systems. And what we see in Latin America is the prevalence of 4 main ways of organizing systems. The first one is the countries in green, where are typical segmented Latin American countries, where you have a public sector providing services to the poor, the social insurance schemes giving coverage to formal workers and their families, and the private sector in general under prepayment mechanisms that provide services to the well-off. The second group is the ones in yellow, where you have universal health coverage, and there is no distinction between who goes where, because there is a solo or very coordinated system, and the people attend to that system regardless of the income, location, or race. And the third country is Brazil. The third group is Brazil, where you have a unique public system that provides services to about 70% of the population, and they are contracting private providers using public funds. And the last one are the countries in violet, basically Colombia, Chile, Argentina, and Uruguay, where the segmentation between public social insurance and private providers remains, but there are intensive contracting between one and the other, and that's the focus of our presentation. When we talk about the Argentinian healthcare system, we have 3 subsystems. The first one is the public, that is marked in our red circle on the left. We have intense decentralization of public services at the provincial and municipal level, targeting the poor. They are financed by general taxes, and no co-payment are allowed. And the way they contract their own services are through fixed wages and budgets, and there are no relation with performance. This public sector overall covers about 35–40% of the population, and it relates to approximately 1/3 of total health expenditures in the country. The second group on the opposite side is private sector. There are 25 private insurance schemes, basically out-of-pocket based, and covering the well-off in the country, and they are supervised by the superintendents of health services and provide one wide package of services, inpatient and outpatient, for the population. There are vertical differentiation in outpatient and inpatient care. The mechanisms of payment for inpatient care is basically based on per case, while the capitation is the traditional payment mechanism for outpatient care. In this group, the country allows co-payments. The coverage is about 10% of the population, and it represents about 20% of total expenditures. And the third group, that is the focus of our presentation, is the social insurance schemes. That there are about 350 funds. They are non-for-profit institutions. They rely on funds collected and distributed by the National Tax Agency, and they are managed by unions. These social health insurance are obliged to cover a program-wide package of services that we call PMO in Spanish, and is also supervised as Superintendency of Health Services. The payment, the refunds are coming from payroll taxes, and no co-payments are allowed. Here what we have is that these institutions do not have own facilities to provide the services, so there are an intense contracting between public and social insurance public institutions to private providers. So there is vertical integration in contract, not in property, and there are two solidarity schemes. One of them is across the social security schemes that we are called the Solidarity Fund and the reimbursement fund, and the other is within social insurance schemes and is called the Solidarity Fund. We are going to be focused in the reimbursement fund that is focused on catastrophic health expenditures. The name in Spanish is SUR, Sistema Único de Reintegro. This solo reimbursement system provides reimbursement to a series of high-cost catastrophic interventions in healthcare to all patients that have the formal coverage with the social security institutions. And that coverage includes diagnosis, radiotherapy, and treatment of all types of cancers, a transplant, prosthesis, Parkinson treatment, stent and heart surgery, treatments for sex change, medicine and treatment for diabetes, HIV/AIDS, among others. Well, we are going to use a series of Lorenz curves to identify, to qualify the performance of this public social insurance private contracting in Argentina in terms of three key variables. One is measuring efficiency in resource allocation. The second is risk absorption across subsystems. And the third one is equity. In order to do that, we are using the data available publicly belonging to 2015-2016 administrative records of the reimbursement system for each social insurance mechanism contracting private providers. There are four key variables that we're going to be using. The first one is coverage, and we define that as the share of the total reimbursement allocated by the reimbursement system to each social health insurance scheme associated to cover high cost illnesses, services, and medicines to their members. The second one is the efficiency in scale, and we measure that as the share of total members per social health insurance schemes over total members of the overall social security subsystem. The third one is the level of risk absorption, and we are using as a proxy the amount of people over 65 years old that belongs to each one of the 300 and something social insurance schemes over the total elderly population. And the third one is an indicator of equity. And in order to do that, we use the variable share of resources available by each social insurance scheme. Overall, the more than 300 social insurance schemes budgets, yeah? So based on that, we are taking the first Lorenz curve, and what we see that is related to the accumulated expenditures overall, the 300 and something social insurance scheme, and on the other axis, we have the number of members accumulated. And what we are saying is that there is some sort of equity in the distribution of resources, but there are marginal benefits of scale associated to the mechanisms of contracting private providers directly by the social insurance schemes and reimbursed by the SUR, the reimbursement system. On top of that, our second indicator is showing that there are clear gains in terms of risk pooling mechanism by using their reimbursement system. The reason is why the accumulated proxy of risk that is on the horizontal axis against the accumulated expenditures show that the Lorenz curve is actually wide, and that allows the cross subsidy between the reimbursement system that is fed by all the social insurance schemes and those schemes with higher number of population under risk. And the third variable is the relation between the percentage of accumulative expenditures overall the social insurance schemes against the financial exposure. That means the amount of resources received in average per capita per each one of these social insurance schemes in comparison to the rest of the subsystem. And what we see here is that the Lorenz curve is showing a much bigger area against the diagonal. What it means that using the reimbursement system structure for high cost contracting private providers allow the reallocation of funding towards social insurance schemes funds with lower per capita premiums. Finally, I will provide some discussion about the performance of this system. First is that the Argentine healthcare system shows how the relation between the social health insurance and the private providers through contracting may be considered as a plausible initiative to enhance coverage while creating equitable access to high-cost interventions through a centralized reimbursement fund. The second conclusion is that, nevertheless, the fragmentation and the decentralization of social health insurance schemes in Argentina, remember we have more than 300 funds, reduce the chances of increasing efficiency in resource allocation. There are no possibility of getting gains based on scale because each one of the funds are purchasing their services and go to the SUR to get reimbursed. So this lack of coordination among funds reduce the effectiveness of strategic purchasing, undermining the financials' bargaining power against the providers. The third main conclusion is that the centralized reimbursement fund might increase efficiency through centralized bids and purchasing protocols and regulations, leading to a monopsony in contracting high-cost interventions, improving overall systems governance. In this case, the point for debate is how social insurance schemes can leave part of their power as purchasers and allow the reimbursement system to centralize not necessarily the contract, but yes, providing some general lines in terms of contracting prices, protocols to reduce average cost and increase the possibility of using the remaining resources to alternative interventions. And lastly, provincial decentralization also allows the creation of local coalitions of private providers facing social health insurance managers, challenging potential changes in the status quo. This will become extremely important after COVID, and the reason is that during COVID, the number of services provided by private hospitals went down because people were afraid to attend to hospitals, private hospitals and services. So there was a reduction in the payment provided by social insurance schemes to those providers. Okay, so I finish my presentation now, and then I give room to our last presenter, Dr. Hasbullah Rabbani. Thank you.
Thank you, Daniel. It's a great presentation. Now, lastly, I would like to present the Indonesian case. It's good to have your presentation with multiple funders for the social insurance. In Indonesia, we have a single fund. We integrated into, we had before multiple funders, but now, like in Korea, we integrated into a single national health insurance program. Certainly, it required a lot of political debate, political fighting to achieve that level. I will tell you about that in 12 to 15 minutes. So I'm currently lead a project funded by USAID. It's called Health Financing Activities. Basically, it's designed to ensure sustainable health financing under national health insurance and strategic purchasing to ensure efficiency in our system. So we are working this until 2024. So I just entering the 3rd year now. First, I would like to share a little bit my thoughts that when we do sustainable financing, we have to be very aware that large pool population group, the larger the better. Yeah, the larger the better. That's why we believe that therefore we made this national level. It's a lot of fight. We had 3 years in a row strikes by employees association and so on to support that. Yeah, public funding also political. Yeah, fiscal space because we want to cover everyone under a single payer and a single benefit for everyone. Comprehensive benefit. It's not that easy, but we managed. We filed about 14 years to reach that level. Yeah, and now we are implementing strategic health purchasing just to convince the politician, legal makers that our system actually already carefully designed to be prudent. The mostly of the political battle at the beginning is population coverage. Because politicians have a very strong interest on this to show to their constituent that they fight for the protection of those people. The service coverage, that's another battle for efficiencies, and also out of pockets another battle. If we have a good political will, we have more at least 90% of the population covered, and out of pocket less than 20%. All services are covered. So this is the dream, the excellent one. Many countries are not reaching this situation because of the politicals, not only because of the fiscal space. The National Insurance in Indonesia, we call it JKN. It's a single payer funded by mandatory tax, payroll tax, 5% of monthly salary. Share 1% by employees and 4% by employers. Unfortunately, the system still currently apply very low ceiling, yeah, of monthly salary. Yeah, this cover every employee can have a maximum 3 children. If they have additional children, they have to have additional 1% from the employees only, because that the will of employees, not employers. The non-wages or informal sector must enroll a family. They have to choose 3 levels of contribution as a proxy of their income. So we designed that one. The benefits still the same, but they have to choose 3 levels representing 3 levels of room and board while they are in hospitalization. The benefit is very comprehensive. We define as medically necessary. There is no exclusion in terms of disease, but we use a managed care technique in the US, which is a closed system that people have to go to a certain healthcare provider. We use a gatekeeper system. They cannot go to a hospital directly. We pay the primary care provider capitation, as in the NHS in the UK. Yeah. So the purpose of the monitoring objective is to prevent catastrophic and the equity. So this is the overall picture design. The pooling fund in the national health insurance is single fund. This then contract public and private providers. For the primary care, we pay capitation. For the secondary care, tertiary care, we pay using DRG or CPG. All over Indonesia are the same. So we have a very strong monopoly power to control the use of the healthcare. The 40% poorest Indonesia are subsidized. They don't have to contribute at all, while the low income informal sector still having partially subsidized. So that's the system work nationwide. Currently, we cover 84% of the population, 224 million people, and we plan by 2024 to cover 90%, but the out-of-pocket might still above 20%. Currently, the out-of-pocket reaching 32%. This is the desire as standard by WHO. This is a growth, a membership growth. This is the integration in 2014. Before this, we have multiple funders like in Argentina or in Japan. Yeah, but despite the increasing population coverage, the system suffered from 6-year consecutive deficit. It sparked the debate, public debate, political debate, why it's deficit and so on. A lot of accusation on fraudulent, poor management, too generous benefit because comprehensive benefit and so on. So that's becoming a political battle, often without evidence. So we, in the project, providing all of this analysis. This is the national health account. The contribution of social health insurance, or because that's based on social health insurance, increasing from 6.5% of total expenditure to 23% in 2018, but currently it's already reaching almost 40%. So this is the evidence that we saw. We provide to politicians, to legal makers, to Congress member or parliament members. Now this is the fact, the situation. So please discuss, debate on the basis of the evidence. Also, we provide evidence as shown also in Argentina. This is the concentration curve or Lorentz for the access for inpatient consumption. This is how cumulative household expenditure. This is inpatient utilization. Number of people who are hospitalized. We observed 28 and 29 for the project. We see this improvement in system. So this is already proper policy. So that's the conclusion. We still have the battle because of the deficit. Luckily, last year, 2020, because of the COVID, many people afraid of going to a hospital, so they didn't go. And therefore, the claims are down and the system enjoy surplus, but that's temporary. But still a lot of debate from that because then some politician, especially the opposition party, said, oh, then this is a proven that previous system are abused by people because the high claim, while during the COVID, the claims goes down. So I said, no, this is because of people afraid they don't go, not because they are healthy and don't use it. So that's another battle that we are still working to find evidence for that. Yeah. The government, after the discussion, because the previous deficit was proven based on low setting of contribution, after the providing evidence, the government agreed to raise contribution or premiums, especially for the informal sectors. But then it became a political instrument by the opposition party, and even the communities, they sue the government. They go to Supreme Court to reject that increase. This is the disadvantage of a mandatory universal health coverage with single payer system. Everybody zoom in the system. The price capitation payments so far did not been adjusted in the last 7 years. So another battle is that the healthcare providers suffering from this system in the 7 years are now fighting to adjust the payment. Although in the previous payment days, some of them match surplus, some of them no. Yeah. So we are working on this with the Ministry of Health and funded by USAID to provide all of this evidence. This is my work for the next 5 years. One of the key important pilots that we are undertaking is using strategic purchasing. I think Sumit at the beginning explained about the theory, and we already implemented. It took almost 2 years to debate to finally agree that we will pay, we will pilot with maternal neonatal health. We pay delivery as per episode instead of per services. So we will pay midwife and doctors at the same time. We use the standard of 5 visit INC. 2 of them, not 5, 6 visit. 2 of them must be undertaken by a GP with USG, and 4 by midwives. So we pay all of this in lump, 2 times payment. So it took a lot of meetings, debate until we finally agree on this design. In addition to that, we also piloting now for the tuberculosis. So we pay providers per episode until patient cure. So instead of per services or per drug or per month, then we pay them like that. So we are applying both political economy and strategic health purchasing. The report will be came out soon and published, because currently we are still implementing this pilot. So as a conclusion, we have a very good concept of adopting all necessary element of healthcare system, which is uncertainties, information asymmetrics, externalities, and all other unique characteristics of a health system into a good policy design. However, only good policy design will not automatically acceptable, because people have diverse understanding of the system. Huge information asymmetries and poor understanding create a lot of political battles. In our system, we spend almost 15 years, 15 years, to battle politically to reach a single payer system. Democratization also somewhat delaying our system, unlike maybe in China or in Vietnam, where they have a still very strong centralized government. In Indonesia, a lot of people went on strike to oppose and so on. This is another factor that delaying the implementation of national health insurance. And therefore, now we are generating evidence to ensure that debate in the future will be based on evidence rather than based on anecdotal evidence. I think this is what we are, or I'm doing with my team to provide lessons for Indonesian, maybe also for some other countries. I think I stop here. Thank you very much.
Thank you very much. Very interesting presentation. We have about 10 minutes left, so we are welcome to receive comments from the audience. There is a place in the discussion forum if you want to incorporate comments or questions. In the meantime, I think that there is a interesting issue that was brought originally by Sumit, and we cover in the three presentations, is about the competition or cartelization of providers post-COVID, right? The idea that during the pandemic, people were afraid to attend to services, and that fact was used by funders to reduce payment to hospitals and providers in general, pose a financial challenge to them. And thinking about what is the post-COVID is important in terms of what is the bargaining power of public and social insurance financiers at the moment of aligning priorities in the way that private providers offer their services. I don't know if you have any comments to this. Over.
I have my experience, by chance I'm in the HFA project. I'm having a special assessment on the COVID, both from the demand side and the supply side. Unfortunately, in Indonesia, the government provide reimbursements quite generous for the COVID because this is pandemics. And many healthcare providers, both public and private, are happy to offer their services to their community. But that's also that taking cost of people of those who are not suffering COVID, saying that, oh, too many COVID patients there, we better not to go to that hospital. We better go to other hospitals that providing less COVID patient than to COVID. This is the situation. We in Indonesia don't have a differentiation in the payment for public and private providers for this COVID reimbursement. It's quite generous as long as they can prove evidence and verification tend to be right, everything, then the Ministry of Health pay that. The insurance mechanism will take over after pandemic, and therefore I and my team are doing the calculation for the DRG part of the COVID when it is going to be endemic in the coming years.
Thank you, Ashmura, for this experience in Indonesia. Any other comments on that? Sumit, Yako?
No, I think it's not directly to Hasbullahs, but a general thing regarding the approach is it's important to recognize that Hasbullah's presentation and also some of the issue that you mentioned regarding the recently is that we should recognize the political economy aspects. So more on to be more specific, the balance and the distribution of power between the key actors and how their roles are manifested, their interests, and also the nature of the incentives that exist, and the kind of other institutional, mainly the regulatory environment keeps on changing as a social health insurance program or a purchasing program is implemented. So it's important to know that the factors that remain at the design phase when a policy is designed and sort of launched uh, changes when it's in the early stage of implementation and progressing gradually to the late stage until it becomes a stable system, like as the NHS in the UK, or like as Hasbullah said, like probably somewhere in the early mid stages JKN. And this the kind of dynamic aspect on how the roles and the tensions and the incentives and power changes is what is important to note. And in order to make impacts, in order to make purchasing really strategic, it is important to recognize these this kind of transitions, these different phases, and then accordingly engage with the different key elements across the stages. Yeah, that's all. Yeah.
Thank you, Sumit. Ayako, you turn on your camera. You have a
Just to briefly respond to Dan's interesting question about, the situation caused by the COVID-19. I'm now currently based in Japan, and then Japanese health system is based on this mandatory health insurance, and Japanese government needs to keep changing the payment rates to pay for the healthcare providers in order to facilitate the healthcare providers to provide services to COVID-19 patients. So, but then I was just curious. I was also reading the policy sort of the responses from different European countries with different healthcare financing mechanism or different healthcare financing system. I was just wondering the financial sort of the challenges hospitals are facing under the COVID-19 differ under a different sort of the health system, for example, between the tax-funded system as well as the mandatory health insurance. So just a brief reflection to Dan's interesting question about the situation caused by the COVID-19 and this purchasing, the changes in the purchasing arrangements between the public, the purchaser and the private healthcare providers and public healthcare providers as well.
Yeah, I think that the COVID not only changed the way we consider healthcare sector as part of the priorities of the politicians, but also is redefining the alliances and the way that providers and financials relate to each other. In the case of Argentina, for instance, what happened is that private providers that usually are tied to social insurance schemes that I mentioned during my presentation, and private insurance schemes also, they work in a separate sphere of the system if you compare with public providers and the ministries of health at the national and provincial level, because they offer service to a middle high income class, and while the public services are focused on the poor. And nevertheless, the way that social insurance and private insurance schemes withdraw their funding to private providers show the need of private providers to go back to the public system and request their help in order to increase the number of consultations and receive some additional funding. And that creates a new alliance, if you want, between providers in the private sector and financiers in the public sector. And my question, actually is not a question, it's an open question, is how this situation would be received by public regulators and policymakers in general at large, and use it as an opportunity to embrace systemic reforms, trying to draw a map to a more coherent and consistent universal health coverage scheme. And this is a debate that we are having now in Argentina, and hope we will start discussing this in the near future. Okay, we have a few minutes left, and we have some communication that the Secretariat of Health Systems Global want to share with us. So if our technical, yes, can share this slide with the rest of the people. Thank you very much. So future scenarios for better health and social justice. Health Systems Global is calling on you to reimagine health systems, identify the changes that will impact health systems now and in the future. Say what is needed to address these challenges. Help us building future scenarios to inform health system transformation. And there you have a link where you can go and participate. Well, if I don't know if my colleagues have any other additional comment to make at this stage. Otherwise, we can close the session. Okay, so thank you very much to all the panelists, and to
thanks for attending. Thanks for the delegates who attended kindly. Yeah, thank you.
Thank you
very much.
Thank you all. Yeah.
Okay, and have a nice evening, night, morning. Take care.
Take care. Bye.
Bye-bye.